So I'm Kristina Kokorelias. I'm an associate scientist at Sinai Health, and I have the esteemed pleasure of kicking off today's EPIC conference with the healthcare and health service delivery presentation. In addition to my short introduction about AGE-WELL and this challenge area, we're very excited to have two EPIC presentations as part of today's session from Jessica and Sheilah and Stuart and Dean, before we'll move into the Moving the Dial presentation with Jay of Able Solutions, Inc. But before I pass it on to the speakers and run through a few notes, I just want to give you in the audience a few notes as well. So we're going to be here together until around 1 o'clock, all throughout Friday of this week, from Monday of Thursday of next week. So please continue to attend all the sessions. Check out the AGE-WELL EPIC Conference webpage to download the EPIC Conference program, and it'll have details on each of the challenge areas. In terms of housekeeping, as I mentioned, we'll have two research presentations, after which we'll have a 5-minute Q&A from each speaker, and you can put your questions in the question and answer or the Q&A box as well. I'll do my best to monitor those. And this is an opportunity for you to also engage with our speakers. Today's session is being recorded and it will be available for playback, and these links will be posted on the EPIC Conference webpage as well as the AGE-WELL YouTube channel when they're ready. I'd now like to turn it over to a few brief minute slides just about AGE-WELL and the EPIC Conference. So as many of you are aware, AGE-WELL's vision is really to be Canada's leader in technology and aging with the benefits of the world, in order to really develop a community of researchers, older adults, caregivers, partners, and future leaders to make the delivery of technology-based solutions more meaningful to the lives of Canadians. And so what we know is that many older adults feel confident using technology, but we also know that they're just not using it, particularly as it supports their health and well-being. The AGE-WELL way, and we'll hear about some of this today, is really around co-creating solutions, having transdisciplinary research and knowledge mobilization, but as well as commercialization, and we'll hear about that more in Jay's talk. These are the 8 challenge areas that you'll see presented, or maybe have seen presented throughout the weeks. And here's what we'll be presenting around today. So the healthcare and health service delivery challenge area is really around increasing access to quality and equitable healthcare for older adults through technology-based innovations that embrace their abilities to live an active and healthy lifestyle. One big key part about AGE-WELL is they are focused on preparing future leaders, and we're very happy to have some early career researchers presenting with us today. And here's where you can find more about AGE-WELL. But enough from me, I will be passing it on to our very first speaker. So today's first presentation will be Jessica Wong and Sheilah Hogg-Johnson. Jessica Wong is an epidemiologist and postdoctoral fellow at the Institute of Disability and Rehabilitation Research in the Faculty of Health Services at the Ottawa Tech University. She is also a CIHR Research and Research Excellence, Diversity, and Independence Awardee. Jessica leads a research program focused on developing innovative strategies to reduce unmet healthcare needs in diverse older Canadians with musculoskeletal conditions. She engages with an advisory committee of knowledge users made up of people with lived experience, family members and caregivers, and healthcare providers for critical impact throughout all phases of research to ensure that the research is relevant and meaningful. Sheila John Hopkins holds an MAth in statistics from the University of Waterloo and a PhD in biostatistics from the University of Toronto. She spent 30+ years conducting research in work disability, musculoskeletal health, and the measurement of health and health service research. She's also an older adult living with chronic recurrent back pain for 10+ years and osteoarthritis in the knee for 15 years and thumb and joint. I will now pass it on to our speakers.
Thank you very much, Kristina. I will share my screen first. And is that showing okay for everyone?
Works well on my side, thank you.
Okay, great. Thank you for the opportunity for Sheilah and I to present our work, a scoping review on structural barriers and facilitators to accessing rehabilitation among older adults with low back pain. Older adults with low back pain often require rehabilitation to improve functioning, which helps with their performing daily activities and participating in meaningful life roles. Low back pain is a leading cause of disability and main reason for requiring rehabilitation globally. However, many older adults face barriers to accessing care, and these are largely driven by non-medical factors, including costs, wait times, location challenges, and accessibility in the socioeconomic and political context. When left unresolved, their unmet rehabilitation needs leads to psychosocial consequences and can further perpetuate marginalization of this disadvantaged group. Therefore, we aimed to systematically map the literature on their experiences with structural barriers and facilitators to accessing rehabilitation services. This is among older adults with low back pain, and investigate how these experiences vary across diversity factors, such as gender, race, ethnicity. I will now pass it on to Sheilah.
Hi, so I'm here today not as a researcher, but as a member of the Advisory Committee of Knowledge Users. And as per the introduction, I'm an older adult who has musculoskeletal conditions that I contend with. We've had 2 meetings to date of the knowledge users with the researchers, and I think there is good engagement in both of them. The first was reviewing the study objectives and methodology, and the second was looking at preliminary results from the low back pain scoping review, which you'll see here today. We had some very lively discussion at the first meeting regarding facilitators and barriers, and you can see the membership there on the left, and they represent lived experience with MSK conditions, family members who are caregivers of people with MSK conditions, and healthcare providers.
Thanks, Sheilah. In terms of the methods of our scoping review, we included adults with low back pain aged 50 years and older who were seeking rehabilitation services, which are strategies to optimize functioning. We framed structural barriers and facilitators to access using the World Health Organization Social Determinants of Health framework, which looks at structural factors in the socioeconomic and political context across governance, macroeconomic, social and public policies, and culture and societal values. We looked to see whether their experiences intersected and differed by diversity factors, including socioeconomic position, gender, race, ethnicity, education, occupation, and income as examples. We searched the literature up to July 2023 for qualitative studies to understand their lived experience, and screened over 7,400 citations using paired independent reviewers based on our eligibility criteria. We then went on to extract data from 16 studies that were deemed relevant on low back pain. We have a separate paper on osteoarthritis, and hence it's included in the flow diagram here. But the key point is that with the 16 studies on low back pain, most of them were conducted in high-income countries. We then looked at the themes on barriers and facilitators to accessing rehabilitation, barriers on the left shown and facilitators on the right. The key domains were as follows. One was related to costs. So barriers to accessing care included issues around costs and lack of funding for community services. However, to overcome some of these financial issues, participants described having insurance coverage, financial support from family, and preferred having fewer healthcare visits where they could have more focus on self-management strategies outside of the clinic visits. In terms of transportation and location challenges, participants described having limited public transportation or parking availability. And for those living in senior housing, they needed special travel arrangements to access rehabilitation. Some participants had challenges with their regular healthcare providers relocating, and for those living in rural areas, also described poor weather conditions as barriers. As facilitators related to location, participants preferred having close proximity to rehabilitation services and having local community resources, as well as support for transportation, such as other drivers that could bring them to their healthcare visit. The third domain was around time-related issues. There were issues around long wait times, limited availability for appointments, and the big time commitment of having multiple healthcare visits, including for those comorbidities in addition to their musculoskeletal conditions. Instead, older adults preferred flexibility in scheduling appointments and more time spent in each visit so that they had fewer visits overall in total. Some other domains of barriers and facilitators were around healthcare-related factors, healthcare provider-related factors, such as limited understanding of the provider's education or treatment, lack of referrals to other providers, and even potentially invalidating or ageist comments that I will elucidate further in the next slide. Instead, they preferred having greater understanding of the provider's education and treatments available. Some participants had a personal connection, such as being a staff member of a facility that allowed them to better access care or having positive prior experiences. The fourth domain was around using mobility aids that I will also elucidate with a theme in the next slide. And lastly, for using virtual rehabilitation, there were concerns for security risks when using an online platform, and participants some of them preferred the personal contact. However, they acknowledged that virtual rehabilitation overcame a lot of the challenges with location, transportation barriers, or living in rural areas. These are the select themes to highlight some of the issues around ageism and potentially stigma related to assistive devices. Participants reported that providers dismissed or minimized their restricting back pain, often with ageist statements, such as the back pain was inevitable, part of aging, and limited their motivation to seek further care. In terms of assistive devices, such as mobility aids or walking sticks, participants did describe a fear of stigma when using these devices. When participants' back pain had disabled them, they had reluctantly resorted to using a cane because it made them feel older or felt treated differently by others. And often to overcome this challenge, older adults would reframe or confront these public perceptions, and sometimes were proactive in using their mobility aid in a more positive manner, such as decorating their device. Overall, these findings of the scoping review demonstrate that there are a wide range of structural barriers faced by older adults with low back pain. And these findings inform a future qualitative study that we will conduct to develop a deeper understanding of their barriers faced and how it intersects with diversity factors. We will also inform a planning and dissemination project where we can consider future research programs and also focus on strategies to remove barriers to accessing care and leverage the facilitators identified. I will now pass it on to Sheilah.
So from the advisory committee point of view, we had quite a lively discussion at the first meeting about our anticipated facilitators and barriers, and quite many of those that we discussed at that point did come out in the findings of the scoping review. So for the most part, we thought those findings resonated with the committee members. We thought that the constructs or the themes of ageism, discrimination, and stigma would be good, that a qualitative study would be a good vehicle to explore those further. So I think that's going to go forward in the planning stage.
And it was overall invaluable to work alongside the advisory committee that included people with lived experience, as Sheilah described, family members, caregivers, and also healthcare providers to ensure that we were appropriate and meaningful in our approaches to the methods, interpreting the results appropriately, and then also gathering their feedback and input critically to inform the next steps of the future qualitative study and considering strategies to remove barriers to accessing care. Thank you so much. I would like to acknowledge that this was funded by a SSHRC Explore grant. So thank you very much for the generous support. And also, if you have any questions, we're happy to discuss further, or you can always reach out by email. Thank you.
Perfect. Thank you both very much for your talk. I see some questions coming in. So the first question I'll pose to you is, have you researched or considered the LBT or LBP of caregivers who need to assist seniors with various activities of daily living that would require physical efforts and or mobility, like helping with showering or toileting? Matches in the... Go ahead.
Thank you. I can start. So my understanding was looking at potentially caregivers of those with older adults with low back pain and having support for them. So we did, in our scoping review, include a broad range of perspectives that included studies that focused on the lived experience of older adults, but also more broadly, their family members, caregivers, healthcare providers, and decision makers in this area. I would say that most studies that we included were specifically looking at the perspective of older adults with low back pain. However, we importantly added that perspective in our advisory committee, where we have a knowledge user who's a family member of an older adult who did have low back pain, to ensure that we have that perspective. And we would like to more broadly consider that in our future qualitative study as well, potentially purpose of sampling not only for older adults, but their family members and caregivers.
Perfect, thank you. We also have a second question. It says, do you address different aids when canes and walkers do not help in alleviating pain or in fact cause more pain?
Thank you for your question. The studies that we looked at focused mostly on the mobility aids of either a walker or a walking stick. Those were the ones that were described by the older adults as participants. And some of them, a lot of the themes that came out were related to potentially fear of stigma in using those mobility aids. In those themes, they didn't describe as much on the effectiveness or ineffectiveness of those mobility aids, but some older adults, when they were able to reframe or confront that public perception, had a more positive experience in using those mobility aids to ensure that they were able to improve functioning, such as in their daily activities or participating in their life roles. But that kind of reframing was often described by the older adults to overcome that structural barrier. I don't know if Sheilah, you have anything to add to that?
I don't think so. And our review was framed at looking at facilitators and barriers to accessing care. So this is kind of a side issue to that, I think.
Perfect, thank you. I don't see any questions in the chat, but I can ask one of my own, which is if you could speak to how your approach to having an advisory committee guide your scoping review might be different from some of the traditional scoping review methodologies that suggest consultation exercise, and why you kind of went with an advisory committee throughout the whole way. And what was that like?
Sure, I can start and then I can pass it to Sheilah. So one was that, so this project was a one-year project. So we recognized the importance of really starting from the beginning, working alongside the advisory committee all the way through. So we actually have planned 3 meetings, one which started with presenting the proposed methods to the advisory committee to gather their input. And in particular there, we explored their experiences as they were comfortable in sharing around structural barriers and facilitators to accessing rehabilitation. And we wanted to make sure that we looked out for those structural factors as we were screening the citations, for instance, extracting data, ensuring that we didn't miss any of those that they've been experiencing. And also, if there were some that they experienced, but we did not find literature on, those could present as knowledge gaps that, importantly, future research is warranted. The second meeting was looking at their interpretation of results. And as you've noticed with our presentation, we had domains of the structural factors, such as costs, time-related factors, ones around mobility aids. And we sought input as well to understand whether that type of categorization made sense, resonated with the advisory committee members. Were there some parts that we either should reclassify or we didn't interpret appropriately? And then the last meeting we will have will be focused on that future qualitative study. But what I'll do is I'll maybe pass it on to Sheilah for any other perspectives on her end.
Yeah, and so I'm wearing both my researcher hat and my knowledge user hat when I answer this question, but I think one of the most important things, and I suppose you could do this with consultation as well, but by having the advisory committee meeting prior to starting is to make sure you have your question right. Are we asking the right question of the literature, and are we asking one that has meaning to the users at the end of the day? So I think that was very important. And then the discussion around the findings too, I think was quite rich. I remember about the stigma and talking about what that stigma meant. And I think that was one we didn't anticipate seeing that was found. Yeah, I'll stop there.
I agree. It was very rich discussions that will help us a lot, continuing to work alongside, work together as we move on to the next phases of the project.
Yeah.
Great. And this perhaps will be our last question, but it says, I still see many old versions of cane and walkers in use. So where are the new designs in tech? Do you know of any affordable age tech product examples?
Thank you for that question. So I guess a few things is with our scoping review, we were looking at published literature. So if they're with kind of emerging technologies that may not have reached that space yet, we would not have captured the newer technology that may be, for instance, at AGE-WELL being presented at the moment, but not yet published. I will say that that's, it's very important for us to consider, because as we saw some of the facilitators that were described, so one was looking at technology in the virtual space. So not only mobility devices, but other ways that technology can innovate to overcome some of the structural barriers. As well, I think with our future qualitative study, it may be that some of the older adults are using some of these technologies to overcome challenges or to better access care that we can explore more deeply through the qualitative study.
Perfect. Thank you. And then I guess this is a more practical question, but would back braces be considered as an aid that is useful? Can you speak on that from your review?
We didn't have any studies. And again, we're looking at qualitative studies because we wanted to understand the lived experiences of older adults facing these structural barriers. So we did not find any relevant studies looking at back braces. However, we've done other work kind of looking at the effectiveness, for instance, of back braces for low back pain in the general population. There aren't as many studies on older adults, unfortunately, for back braces. So that's kind of a different area. For the most part, I believe the evidence is suggesting to be cautious in using back braces. They're really considering that person-centered approach on whether it's helpful for that individual. But again, for our scoping review, we did not find any relevant studies on it.
Perfect. Thank you so much, Jessica and Sheilah. I know that we will have a general Q&A where we might come back and revisit those. And I also know you guys kindly shared your email, so anticipate some questions there. With that said, I'd now like to pass it on to our presentation number 2 with Stuart and Dean. So Stuart is a second-year medical student at the University of Toronto, St. George campus, class of 2026. He completed his Bachelor of Health Service Honors at McMaster in June 2021, where he developed a keen interest in health promotion and community medicine. He is passionate about quality improvement in healthcare and sustainable implementation through equitable means. And joining Stuart today is Dean Valentine. Dean is a veteran with the Royal Canadian Navy. His experiences and professional competencies were gained through 25 years of experience of service to the Canadian Forces and over 14 years of volunteer community service work. Dean self-identifies as a member of Toronto's queer community who is HIV positive, having complex medical and mental health challenges as he navigates mild to moderate cognitive impairment. Currently, Dean is a board member of Casey House Hospital, appointed advisor to the Minister of Health's Patient and Family Advisory Council, and sits on addictions and mental health panels for Ontario's Persons with Lived Experience and Living Experience Advisory Panel. Dean is actively involved in community research projects in the HIV and mental health and addiction services sectors. And with that said, Dean and Stuart, the floor is yours.
Thank you, Kristina. I'm just going to take a moment to share my screen. All right. Hopefully everyone can see okay. Hello, everyone. My name is Stuart McKinlay. I use he, him pronouns, and I'm a research assistant at Sinai Health in UHN in the Department of Healthy Aging and Geriatrics. And as Kristina mentioned, I'm also a second-year medical student here at the University of Toronto. I'm actually calling in from one of the hospitals, so if there's any overhead announcements, I apologize for the interruption. I'll just be pausing my microphone until that concludes. Today, I'm so pleased to be joined by Dean Valentine. Dean, can I pass it along to you to introduce yourself?
Certainly, thanks, Stuart. So I will just say that based on the research we've done, I'm currently a board member of Casey House Hospital and a member of the Minister's Patient Advisory. And I really consider myself a community advocate for peer research, community engagement, and co-design approaches to program development. So related to this particular kind of study, I myself have lived experience. I'm a 58-year-old, a member of Toronto's queer community, living with HIV since 2008. So I'll leave it there.
Thank you, Dean. So everyone together, we're going to be co-presenting a qualitative study which focuses on exploring the perspectives of older adults living with HIV on the use of virtual care services. And so before we dive into our discussion, it's important to set the stage by examining the intersection between HIV and aging in Canada. So acknowledging the significant advancements in care over many years, and this includes antiretroviral therapies, we now know that individuals with HIV are experiencing greater quality and quantity of life than ever before, with life expectancies that are largely mirroring those of the general population in North America. As a result, nearly half of adults with HIV in Canada are now aged 50 years or older, and this underscores the pressing need for specialized geriatric care within this specific population. Now, we know that age-related comorbidities and syndromes are increasingly prevalent amongst older adults living with HIV, and this necessitates tailored care from experts in gerontology. This can include geriatricians, as well as geriatric clinical nurse specialists. Now, unfortunately, we know through research and through anecdotal evidence that there are significant barriers to care that exist for older adults living with HIV. Dean, if I can pass it along to you to speak a little bit about some of these barriers that we're going to be mentioning on the slide.
Okay. Access to geriatricians is generally limited, amplified by the shortage in Canada. There are fewer than 400 geriatricians and 18 geriatric nurses. For those of us living with HIV, barriers to access geriatrics are challenging and exacerbated by HIV stigma. The unique management of HIV compared to other illnesses. Intersectional identities introduce further hurdles in accessing HIV care. The intersection of HIV stigma and ageism compounds the challenge in accessing specialized geriatric care for those of us with HIV. I wanted to add here that stigma, while generally is outward, may also come from our own stigmas with HIV and aging, and that's really important in the interviews we did. While the team has explored pilot geriatric HIV care models, none have considered the importance of intersectional, culturally appropriate care and the implementation of that in Canada in rural settings. Research indicates that geriatricians may lack confidence in providing care to individuals with intersectional identities. underscoring the necessity for tailored geriatric care for diverse older adults living with HIV. And Stuart.
Thank you, Dean. So considering all of these aforementioned points, and particularly in light of the limited availability of geriatric care specialists in Canada, we recognize that virtual care can potentially enhance healthcare accessibility for this population. However, it's also important to acknowledge the disparities in access to and utilization of technological services amongst older adults, as well as barriers to digital literacy amongst marginalized populations or older adults. What we do know from research is that there's a strong correlation between inadequate digital health literacy and adverse health outcomes. And this emphasizes the importance of considering digital literacy and the digital divide in the provision of virtual care for geriatric populations with HIV. And so understanding the perspectives of older adults with HIV regarding virtual health services has the potential to aid in refining future virtual healthcare provisions for this demographic. And so the objective of our study was largely threefold. It was to explore the experiences and opinions on virtual HIV healthcare amongst older adults with HIV, to examine the potential benefits and challenges of virtual healthcare services for this group, and to identify factors that influence the acceptance of and utilization of virtual healthcare for this population. Dean, if I could pass it along to you briefly to speak about the methods of our research.
Thanks, Stuart. The method used was a qualitative study using semi-structured interviews. 14 participants were eligible. They resided in Ontario and they self-identified HIV positive and were 50 or older. Efforts were made to recruit individuals with varied experience with virtual healthcare. Thematic analysis was conducted following the quantitative analysis guide of Levin, guided by HIV positive peer researchers like myself. And for myself, I came in early on, so some of that semi-structured interview was there and had advice. Transcripts generated from the audio recording were color assigned to text conveying group concepts for a codebook. And
Great.
over to you, Stuart, please.
Perfect. So as Dean had mentioned, overall 14 participants shared their diverse experiences with virtual healthcare, and some central themes were identified. And these included: one, the utilization and access of virtual care services was spurred by the COVID-19 pandemic. So we know that the COVID-19 pandemic accelerated the adoption and use of virtual healthcare. And this really underscores its significance as a delivery modality for this demographic in this day and age. This was evidenced by one of the quotes that we extracted from our interviews that said, "We're moving in the right direction, that people trust this way to virtuality. It's a matter of using it, trusting it, and engaging." The second theme that we were able to extrapolate was the importance of patient-provider communication and relationships. We know that virtual platforms provided a safer environment for connecting with new providers for some of our participants, facilitating access to healthcare services while overcoming some of this. For example, Distracted said, "I must say that's the only difficulty I find when I have to share my medication or my status in a more public area. I find it more difficult than being on the phone." This quote itself emphasizes some potential in-person challenges that can be mitigated by one-on-one virtual communication. However, some participants did raise some concerns about the challenges with establishing long-term trusting relationships with their healthcare providers. And finally, the last point was the importance, or what we were able to determine was the satisfaction with virtual care and the effectiveness of virtual care. So some participants recognized that virtual care was convenient for accessing care within their preferred locations, but some participants also expressed a lack of resources available for learning how to use these services most optimally. And this resulted in some detachment from their healthcare teams and some feelings of isolation and helplessness as well. And so overall, our study highlights the importance of the following principles. One, these results emphasize the importance of bolstering mechanisms that foster trust between patients and providers, both in the short term and the long term through virtual means. And two, that utilizing the convenience of virtual platforms to improve the accessibility of person-centered healthcare is important for this demographic. and doing it in ways that ultimately optimize healthcare outcomes in the short term and the long term. Dean, I'd also like to briefly pass it along to you to discuss some future considerations in this research, including the use of co-design methods.
Yeah, for me, this goes in kind of a very interesting area for myself, and I'd like to take an opportunity to acknowledge and highlight the importance of co-design approaches and meaningful engagement with lived and living experience. So really meeting people where they're at in safe environments and being able to provide that safe space. I believe this was a great example of some of those approaches that we're learning along the way, and how it can be developed so that we may provide more inclusive, safe space and opportunity for diverse experiences for those of us living with HIV. And I really want to thank Stuart and team for all the work getting us organized and taking the lead in the approach to presenting this. It's really been done in a co-design approach where lived and living experience is put into all elements of the study. So I really want to emphasize that and really want to be thankful for the opportunity to share my own personal experience, but as well to make a safe platform for meaningful engagement of other people with lived and lived experience. So thank you, Stuart.
Yeah, and thank you so much, Dean, for your expertise and mentorship in this area. I would also like to acknowledge the following members of our research team for their contributions and expertise in putting together this project. And our final slide is just some references that we utilized in the making of our presentation. Thank you so much. We're happy to take any questions you may have.
Perfect. Thanks so much, Stuart and Dean. We see lots of praise coming out in the chat. And Dean, there's a lot of praise thanking you for being there. So thank you. I know you both kind of alluded to some of the co-design and the co-collaboration that's kind of happened. And can you speak to any next steps of this partnership along this period of line or this line of work?
Sure. Yeah, so certainly I can start us off. I think largely speaking, as Dean alluded to, the importance of co-design in the implementation of future piloted projects. So once we actually have the opportunity to, engage with those with firsthand knowledge of some gaps or challenges in our healthcare system, then utilizing what we've learned in order to make it better. So one of the first steps largely is putting together a larger program of research where we're going to co-design a protocol for HIV geriatric virtual care, working alongside as we mentioned, community members and interprofessional collaborators, and then assessing it throughout the course of its implementation to see what is working, what's not working, and continue to improve it from there. So largely the first step is taking this information and putting it into a prototype for a virtual care model.
And then I think I would just jump in there and say that doing that in a way that we provide the opportunity for lived and living experience to work at each level of the research. So the brainstorming to start off, I was involved in and invited in. So that kind of really influenced the semi-structured interviews. And then in those interviews, the lived and living experience, the information we got, that directed kind of the next stages and where we could use the information received and how that could be coded. And I want to say along the way, it's reaching out to different sectors of the research team and having a lived perspective, I think, in all of those. So it's a really good model of co-design. It's being done more and more. We've learned, but I think part of it too is exploring kind of meaningful opportunities to have lived and living experience, have a safe space to share their experience and to share their challenges. And sometimes that's really open space because we're used to directing it in certain areas. And I think we've had the provision to open it up to hear what people have to say rather than specific certain areas. So I want to say that along the way, the lived and living experience is really directing the direction where the study is going, and then the provision of care at the end and what we might be able to do with the study and where it may be used.
Perfect. Thank you very much. And now we'll turn it over to our Move the Dial presenter, and I will invite Jay Singh of AGE-WELL Innovations to please join us.
Hi, thank you so much for having me.
Perfect. So AGE-WELL Innovations develops empathy-driven technology. AGE-WELL's robotic ALTA platform automates one of the most painstaking and uncomfortable tasks in healthcare, lifting and moving individuals. Their technology delivers a safe and effortless experience of healthcare staff while offering clients a comfortable and dignified experience. As AGE-WELL continues to push through the technical barrier, it aims to transform how and where individuals spend their golden years by providing technologies that automate the highly labor-intensive tasks involving with caregiving. Jay, I'll pass it now on to you.
Thank you very much for having me and appreciate the time. As you mentioned earlier, our goal at AGE-WELL Innovations is to automate one of the most labor-intensive tasks in caregiving. And just to tell you a little bit about my personal journey into the space, because I'm an engineer by training. I've worked on robotic systems in various industries, but I was exposed to the problem of patient transfer specifically, which is moving individuals between beds, wheelchairs, was when my mom began working in long-term care facilities, and just hearing it through dinner conversations first about how painstaking this task is, and then witnessing it firsthand as I began to volunteer in long-term care facilities, and then seeing my mom and her peers begin complaining about chronic aches, as well as interacting with the residents and patients and seeing how undignified they felt when they were transferred. So specifically, the act that I'm speaking of, I'll be focusing on today is that of lateral supine transfers, so which is moving individuals from a lying down state to a lying down state. However, in the future, the goal behind AGE-WELL Innovations is to transform patient handling in all different states. So our flagship technology, which we refer to as the ALTA platform, allows only one caregiver to conduct these transfers at the push of a button, as opposed to needing a team to assemble, exert backbreaking effort in a manner that also really invades the personal space of individuals who are being transferred as well. Just understanding the problem a bit further, today there are acute staff shortages in healthcare. And this is one of the tasks that requires the most amount of resources to assemble and conduct these transfers. And healthcare operators are starting to understand the costs associated with this. As staff are getting injured, they're trying to find ways to retain staff, but also it's leading to significant inefficiencies. If you don't have people to move individuals in facilities, that results in fewer procedures, for example, as well as it results in a really, really poor and undignified patient experience. So in order to solve this, we developed the ALTA platform, which allows the same transfers to be conducted at the push of a button. And we've really utilized the latest and greatest in technology to develop a solution that's really easy and simple to use. We've interacted with clinicians from the early onset because we recognize, we may be technical and experts, but we don't have the knowledge when it comes to clinical applications. And we've also really involved older adults in the design process of our technology. I'll go ahead and show a demonstration of our product and how it works. So our device looks like a common bed or a stretcher, but it's meant to do a lot more than that. So all the user has to do is align our device next to the patient's bed, and then a compact conveyor belt type platform. It detects the bed and starts rolling under the patient in a manner that it doesn't tug on any delicate skin. And it's actually a very comfortable experience. And then they're shuttled over onto our device. And then they can be taken on to the next appointment or wherever they may need to go. Now, in addition to this, we're really focusing on providing key value to operators. So we do provide data such as, who's moving the patient, where, when, and analytics such as that. In addition to that, we've really focused on the caregiver and the nurse experience too, so allowing them to move the device effortlessly. So we've come up with a suite of features that, we have force sensitive handlebars, and then the user can, without any effort, can move the device effortlessly. And then we have sensors such as object detection, etc. I'll just attempt to show you what our first customers are saying about us, and do let me know if the audio doesn't come through.
Able Innovation's Alta platform really came to life to solve a clinical problem for hospitals in 3 areas. So patient safety and better patient transfers, staff safety, ensuring that staff are able to be working and having the tools required to safely transfer patients, and finally, staff efficiency. So how staff can use this platform to do transfers by themselves rather than the classical two staff or more to transfer a patient. The real world problem that the Alta is trying to address is that currently it takes at least 2 staff to be in the room to transfer the patient, and the Alta can allow for a single caregiver transfer. In addition, patients experience stress on their body from the slings that are used, and the Alta can reduce that as well.
I believe that using the Alta is going to be very helpful to our unit. One person only can do by themselves transferring the patient, and then also it will help to prevent more injury of the patient.
The ceiling lift, if you're a male, can be a lot more tightening. On the ultra lift, it's very easy to get onto it, and you don't feel any strain.
There's really nothing like hitting the front line and actually interacting with patients and nurses, and that's been tremendous for us. We've been able to implement additional modalities in our transfer functions. We've been able to improve our workflows and our human-machine interfaces, and it's helped us iterate that much faster than we could if we were trying to set up simulations and things like that back home.
So, as we're meeting the challenge at short-staffed facilities, there is a lot of focus on our technology's ability to help facilities retain staff and enhance clinical efficiency. And now we're seeing a lot of refocusing on the patient experience and patient dignity. As a result of that, we're launching across Canada as we speak, with a key focus in geriatric care and complex continuing care. Other areas that are looking at the benefits our technology could provide are clinical areas such as diagnostic imaging or even surgical wards in progressive facilities. I just wanted to talk about how we got here. So as I mentioned, I'm not from the space, so I started developing prototypes, transferring dolls, quite literally. And would like to thank AGE-WELL for helping us de-risk the technology and help us throughout our progression in connecting us with key clinicians, researchers, et cetera. And for us, it was the Sensors for Aging and Mobility Hub out at Carleton University that was pivotal for us. The first question was, is our proposed method of transfer safe for human skin? And that's where we published some articles on how it is 4 times safer in terms of the forces exerted on the skin are 4 times less. Then we had clinical assumptions that we were directing our technology to be able to pick individuals who've fallen on the ground up as well as transferred them. And we were able to get to have access to clinicians and really understand that sometimes it's more important that the device is able to transfer individuals in all settings rather than pick patients off the ground. So we changed the product there as well. And every step of the way, the device got larger, and then now we have a product that's productized. We feel very proud about it, and we're continuing to push the technical envelope there. And as I'm speaking about the product roadmap, right now we're focused on lateral transfers, but our long-term goal is to transform how and where individuals spend their golden years. There's a lot of work being done on e-health, but we believe that the physical acts of caregiving cannot be replaced, and it does put burden on the caregivers. So our vision is to transfer individuals, for example, between beds to wheelchairs in their home care setting down the road, and we're taking a lot of the learnings from this technology and we'll translate it over. There's nothing like us that exists in the market. Everything is very manual to date. And I'd just like to acknowledge our team that's behind this. We're highly dedicated. A lot of us have had personal experiences. Our loved ones have had personal experiences with transfer and the importance for dignity. And I'll kind of sum it up with the key drivers behind our venture. One is market trend. It's undeniable as we age as a society that health systems do not have capacity. We definitely have a lot of purpose in terms of trying to help our older adults as well as the caregivers. And as technologists, we really are pushing the technical envelope, and we feel very proud about that. With that said, I'd be open to any questions, and thank you so much for taking the time.
Thank you so much for a great presentation, Jay. There is 2 questions in the chat. The first one is asking if you'd consider other transfer mechanisms to help transfer patients from the bed to a bedside commode or toilet.
Yeah, so that is a significant issue in healthcare. There's a lot of, I guess a lot of the transfers are conducted either using a team, you have slings, or you have transfer sheets. That's all that we've seen in the market. Right now, our technology doesn't allow for that. In the future, we do want to automate that transfer as well.
Okay. The other question is asking just for some clarity around the units. So are they mobile and size appropriate to move between different units easily, just because they might not be cheap and hospitals are stretched financially?
Yeah, absolutely. That's a great question. So one thing that we're really focused on is not on trying to make a profit. It's really trying to understand how we solve this issue of rising operational costs. So the cost of nursing, the cost of an injured nurse is way more than, for example, a device would be. And our device is not a bed that a patient stays on. Our device can touch as many as 20 to 30 patients a day. So we're really focusing on providing value across a ward, let's say, not just that it stays with one patient, and that allows hospitals to justify the value for our technology. And it is very mobile, just to stick with that. It's the same size as a normal stretcher, and it has additional mobility aids where we have powered wheels that allow it to be moved easily.
Perfect, thank you. I have a question for our co-researchers, Dean and Sheilah. Sheilah, what was your motivation for undertaking or being involved in the research that you did participate in? Either one of you can go first.
I think it gave me a voice to talk about my health issues and access to care. So I was listened to, and my input was appreciated, I think.
Yeah, I would echo the same, as well as I want to say in retirement, I've been doing a lot of community engagement, and I've seen a lot of initiatives and programming services that are moving forward and really looking at kind of client or patient experience at the end, but they miss kind of some of that beginning work. And for me, it's really trying to put a co-design, a solid approach on co-design. So it's getting in early. And so that was an opportunity. And if I see research opportunities for that to do peer research, I will take it on. So that kind of it built momentum, and we see it more and more in the research.
Thank you. And the question for Stuart and Jessica is, what have you learned as early career researchers working directly with older adults in your research? Jessica, you want to go first?
Sure, I can go first. So one is really, I think, having a diverse perspective on the complex problems that we're being faced with. So through the advisory committee meetings, I've been able to listen to the experiences of older adults and their family members and caregivers. That really is outside of my researcher perspective, and ultimately bring back the insights that are ultimately to help the communities that we serve as researchers. So I've been learning to listen, learning to really work alongside knowledge users from the beginning. And as Sheilah was mentioning, even back to the objectives of the research, because ultimately we want to be able to work together to create solutions to problems that are being experienced by those communities. I've also been thinking a lot more about ensuring that the research is meaningful, that I'm interpreting what we're seeing from the research findings appropriately in the right context. And again, really working alongside the knowledge users with their experiences are most important. So I feel like more and more I'm seeing myself as kind of a vehicle or there to help, you know, support the work, but really I'm working alongside and with the communities.
Yeah, that's a great answer, Jessica. To share my thoughts, positioning myself as an early career researcher as well as a medical student, I had opportunities to engage with patients both within this research team, but also in my training and learning. So some broad considerations that I've learned to recognize is the complexity of healthcare needs. Older individuals, including but not limited to those with HIV, they have complex healthcare needs, perhaps due to the virus itself, but other potential comorbidities. And so as a result, there may be multiple medications that are prescribed in polypharmacy. And in a position as a physician, you recognize the limits of your own knowledge and what you may need to rely on interprofessional collaboration, such as a pharmacist for medication reconciliation and things of that nature. And so it's your responsibility as a healthcare provider to be sort of the conduit in terms of setting individuals up for success. So how do you do the referral process? How do you inform the individual of what some of the next steps are in order for them to be able to take care of their own health and take health into their own hands? So I think for me, understanding, that there are some long-term management needs in older adults, the importance of continuity of care. And that also brings upon the piece of virtual care as well. Is I think a lot of the virtual care implementation that we have at this point, it sort of works in these silos where you have virtual care appointments or you have in-person appointments, but it's oftentimes a lot easier to sort of coordinate next steps in person than it is virtually. And so what are some things that can be done in terms of overcoming and mitigating that barrier so that virtual care achieves the same quality of care that in-person care modalities have achieved for so many years? And so I suppose, broadly speaking, working with older adults as a researcher and as well as a medical student, understanding the complexity of care needs and how relying on interprofessional team members is so crucial. And how do you set patients up for success in terms of continuity of care so that they never feel like they're slipping between the cracks?
Perfect. Thank you all for your time. Such a great perspective from all of you today. And as I said, this will be recorded. We're just at 2 minutes to 1. And thank you to all our great presenters. And I hope to see some of the rest of you at the rest of our AGE-WELL sessions. Please don't forget that there's 8 sessions tomorrow, and tomorrow's from 12 to 1. Thank you.